work program. Oh, got it. That took place in the last couple of years in Rwanda, with support of Pia and a broader team that she'll present to us in a minute. And I think sort of the reason why we wanted to organize this webinar around that work program is because it's really nice example of, at least for us in the GFF side, we're sort of channeling quite a lot of these drum grants to country teams. It's a nice example of how that support is really used for supporting a government with implementation of a fairly ambitious health financing reform agenda, while also really very strategically leveraging the bank instruments, in this case, the human capital development policy. So we'll hear from Pia about sort of what happened, in what context, what sort of work was done, with what sort of impact, after which we'll open it up for questions and discussions with all of you online. So Pia, very happy to give the floor to you. I don't think you need an introduction. I think everyone knows you very well. Pia, lead economist in the bank. Please, floor is yours to walk us through the presentation.
Thank you very much, Ellen, and welcome, and thanks for joining this session. So as you know, this is really about sharing with you the experience on the work that has been produced by the team to provide technical assistance in Rwanda to support the implementation of the development policy operation. The Rwanda Human Capital Development Policy Financing was a series of 3. That was the correct title, actually. And it lasted from 2019 to 2022. Actually, it's just going, the 3rd one is just going to the board tomorrow. And there were all over 3 prior action. It was a multi-sectoral operation. And 3 of those 9 prior actions were related to health. Prior action 3 was about health insurance reform, prior action 9 about health workforce reforms, and prior action 5 about nutrition-based budgeting. We used the GFF money to finance technical assistance to all 3 of them, but today in the presentation I will focus on prior action 3 on health insurance reform. So the outline is really about what is the issue first, then policy reform program, the technical assistance delivered, and the proposed next steps. So first, what is the issue that we try to address here? As you probably know, the Rwandan health insurance enrollment rate is quite high. It's about 75% of the population was insured based on the household survey in 2017. And here you see a chart on the percentage of sick individuals who sought care. The dark blues are those with CBHI.
Pia, you need to advance the slides. We can't see them.
Oh, sorry, it has advanced on my. Can you see it now?
Not yet.
No, we're just seeing but we're not seeing it in slide mode. We're just seeing slide 1.
That's strange. Okay, let me bring this up again then, because it's bizarre. Probably I did something wrong. I'm sorry about this. I should know by now to show those slides. Can you see this?
Yes, we see the bar chart, but not in slide mode. Oh, yeah, okay, if you click that.
Oh, okay, good.
We see the slide, but not in slideshow mode. At least I do.
Let's see it, try again. Now? Yeah. It's bizarre. Because on my screen, it is on slide share mode. But I see it's not here. I honestly, I don't know. I think I'm just going to go on.
Yeah, we can see it as long as you move. Oh.
Are you using two monitors?
Yeah.
There.
Yes.
Okay. Click on now. Click on display settings.
Yeah.
And
duplicate slideshow.
Yeah.
Good. Thank you. Now it works, right?
Yes. Perfect.
Yes.
Thanks,
Thank
Victor.
you so much for your help, whoever helped me here. So again, you can see here, this is household survey data from 2017, where we showed that the percentage of sick individuals who sought care was equally high among the mutual or CBHI insured, as well as the other insurance people with other insurance, but it was considerably higher than among those people who had no insurance. So it does provide better access and equal access to care, but there is a high and growing annual deficit. So that then caused the government to issue in 2019, at the National Leadership Retreat, the government issued a resolution to ensure the CBHI financial sustainability. So I should say these government national leadership retreats are like where the government gets together and they focus on 10 resolutions, and these are top priorities for the country to focus on. Under the DPF series, we then address this under the prior action 3. As I said, it's a series of 3. Under the first one, we focused on increasing revenues through a Prime Minister's orders. And under the DPF 2 and 3, we focused on managing expenditures, because financial sustainability is about revenues against expenditures, right? So I'm going in more details now into those 3. I will not read them out here. The GFF-funded technical assistance really had 3 components. The first one was health insurance operational management. The second was about analytical capacity building. And the third one was health insurance management information systems. We used these 3 components to support the DPF, the implementation of the DPF. I'm just going under the first one, under the first component on health insurance operational management and policy reforms. We really had several actually actions that we supported there. I'm going to highlight now 4 of them. The first is on the domestic resource mobilization or transfers from the Treasury. The second about the benefits package. The third is about data protection. And the fourth is about capitation payment. Okay. So the first one, the health insurance law. There is a health insurance law from 2016, and that law actually says that the government is supposed to finance or to subsidize the enrollment of the poor. However, it has never really been clarified how this is actually supposed to happen. So we provided technical assistance for the government to develop a Prime Minister's order. So that would be a governmental decree to define and increase the government transfer from Treasury to the CBHI. So what this says is that the transfer will be 6 billion as a state annual budget allocation plus 3,000 francs for each person in category E, which is the poorest of the UBDE classification system, which is a type of social registry. And I should add that the social protection team had another prior action where they were revising this targeting mechanism to make it more accurate, to make sure that the poorest really get to benefit from this transfer. So as a result of this, you can see it had an immediate impact. The revenues increased from 2019 to 2020 because of more transfers. There were also transfers from telecommunication companies and from other insurance companies that made transfers. And the annual deficit decreased. It was not completely going away, but it was lower in 2020 than during the previous years. So under the DPF2 now, the second part, we focus on managing expenditures. And one of them is, of course, the benefits package. The health insurance law says that the ministry should issue an instruction on what is supposed to be covered by the benefits package. Well, that ministerial instruction has never been issued. And so now under the DPF2, we provide technical assistance to the Ministry of Health and the RSSB to issue this ministerial instruction, and in particular also identify what are the criteria based on which the decision should be made, what is to be covered or not, right? Because we live in a world of finite resources here. Not everything can really be covered if you don't want to have a deficit. So among the criteria that were listed here is, I just copy a couple of them. The impact, the treatment should have an impact of the health problem as measured by financial cost, mortality, morbidity, or the combination, or the treatment, the degree to which the treatment achieves its intended purpose. The ministerial instruction also requests the establishment of a committee to supervise the entire process. So just to give you some more details on what's actually happening here. The RSSB and the Ministry of Health have then hired the London School, and they, together with the Public Health School in Rwanda, are going through all the conditions on the burden of disease of Rwanda, and they're mapping it with the treatments. So what is the standardized treatment that you need for the different conditions, right? So like, for example, condition, pregnancy, what is the treatment, ANC, and so on, right? And then they add the codes that would relate to that. So the diagnostic codes and the procedure codes. They will then go through with all the criteria, through all the conditions and treatment to rank them according to their priority. So they will end up with a prioritized list, right? So certain things have a higher priority, like pregnancy, than other things like rhinoplastic, for example. So the rhinoplastic will probably rank further below, but at the end of the day, they will come up with a prioritized list of conditions and treatment that will be important for Rwanda. And once they have the list, they will send it to the RSSB actuary to ask, well, what's the budget? How much money do we have? And the actuary will then more or less say, okay, here is how much money we have. It will be sufficient to pay until condition and treatment 471, and whatever is below cannot be covered. So we need to find either money to increase the budget or another way to pay for the other conditions and treatment. So this exercise is still going on, but it will provide a very explicit list of conditions and treatment that will be that can be financed by the budget, right? At some point, the discussion must be held, because we live here in a public system, in the public health system, who should actually pay for what part of the expenditures. So for example, if on the condition and treatment, we say treatment includes the pharmaceuticals to treat this condition, then the question should be asked, well, what percentage of the pharmaceutical cost should now be paid under the benefits package? Because there are other sources that finance pharmaceuticals for health facilities, right? So should in the future the DPs, the development partners, instead of financing pharmaceuticals separately, as well as the government, should this money be actually to be transferred to the CBHI, and all the pharmaceutical expenditures will then be covered under the benefits package. But that means that the money goes with it, right? If you have more responsibility, then these funds should be moved over to the pharmaceutical budget at the RSSB, who will then pay 100% of the pharmaceutical expenditures, for example, right? So this discussion needs to be held at some point across the payers to prevent that there is double payment of certain expenditures, which is probably already happening now. Now, related to that, we also supported under that prior action the development of a claims form to be used by providers. The claims form is the form that the provider fills in when you seek care and sends it then to the insurance company to get reimbursed. These claims forms are not very thoroughly used in the world. Are not very good, and so we actually supported the government with identifying what are the variables that need to be collected in a claims form, and how should that claims form then be structured. And ideally, this data then gets transmitted electronically of course, for every case that seeks care in the health facility, so for every insured members. Now, the third one is about data protection. I wanted to highlight this because this is actually happening now across Africa. A couple of years ago, the European Union has issued the new data protection law, and this law is pretty strict. And actually, if you take it really seriously, if you are if you have citizenship of a European member country, and one country in the world is misusing your data, that country can actually be sued under the European Union law. Now, what has actually happened is that several countries in Africa have followed suit and issued their own data protection law. When we looked at this, it was 14 countries have actually issued their data protection law. And they usually means that the institutions in a country that collect personal data have a certain time to implement, to get ready for the law, and then the law needs to be implemented, right? So that is very important for insurance companies because they collect personal data from their members and patients, and that can be misused. So following the law is very important here because people could otherwise use the law to go against the insurer. So in 2021, after that the law has been passed by the Rwandan Parliament, we prepared a guidance notes for the RSSB on how to prepare the data protection policy and procedures. So every insurance company now needs data protection policy and procedures on how to handle data, how to manage data and how to also destroy data once they are not being used anymore. In January 22, we organized a workshop for management and staff on the new law for the RSSB, the Rwanda Social Security Board, who is managing all the public insurance program. And in February, we also prepared a note for the RSSB on the organizational structure. So they would have to hire a data protection officer and an information security officer, and we also prepared the job description. So this is currently being implemented. They are taking this very seriously. The data protection officer is reporting to the CEO of the RSSB, but also has a reporting function to the National Data Protection Authority, who is in charge for implementing that law across the country. So this is currently being set up, but I thought I mentioned this to you because this could also be relevant in the countries where you're working on when you work with health insurance. So it may be good to check whether there is such a law. We also identified the next steps that need to be implemented based on the law. So first is appoint a DPO, a data protection officer, carry out the gap analysis based on the law, what is needed, and evaluate the legal readiness of the institution. So I'm not going to go into details here, but these are the steps that need to be done now. So the fourth part, and that was on the DPF3, we provide a technical assistance to a ministerial instruction on provider payment reform. Actually, the law, the health insurance law from 2016, does not have any language on provider payment, which is not bad, which is actually pretty good. That gives some leeway. But the health financing strategy says that the provider payment, which is currently fee-for-service, should be moved from fee-for-service to capitation for primary health care and to case-based payment for secondary and tertiary providers. So under the DPF3, we provide technical assistance to the Prime Minister's order to issue that legal language to move that to that capitation payment mainly. So just a recap what that means, capitation payment. We also supported the implementation and the preparation for it. We prepared the calculations and the roadmap. But what that means in the future is that when CBHI members enroll, they enroll usually for 1 year. When they sign up with the CBHI, they also register with their preferred provider. So that would be their preferred health center. It's usually the health center where they live, so the catchment area. And the health the RSSB or the CBHI then transfer every month the capitation payment per member per month based on the number of registered members, right? So that is not so easy, because currently actually we realized that members, when they enrolled, they could not identify their CBHI, their preferred health center. So that feature is currently being changed by the IT team at the RSSB, so that in the future actually members can identify their preferred center, which then also gives the RSSB the necessary information on the financial transfer that needs to happen. I'm not going in details into the roadmap of the capitation, but if you are doing capitation in any country, I would be happy to share this with you, because it includes a couple of very detailed steps, but we provide a technical assistance to that roadmap. Now, as part of this, we also organized workshops on case-based payment, because they were very keen about introducing also case-based payment. But here, we really wanted to, highlight this is a multi-year process, and this is not something that's going to happen overnight. And we used a framework from that has actually been developed by the Germans. And that includes 4 building blocks. And these building blocks include patient classification system, data collection, cost calculation, and reimbursement. Going through those 4 building blocks really takes time. It will take several years to reach stage 4. It takes several years in any OECD country. So it will also take several years in any low-income countries. Okay, it's not possible to do this immediately. But what in Rwanda is now the top priority is number 1, which is the patient classification system. And then, the claims data, the data collection, number 2, so that actually the correct data are being collected and good data are being collected. So what does this mean? It means that hospitals will need to collect data on medical diagnoses and procedures. And usually, most countries use now the ICD-10 and some procedure codes. In the US, we have CPT codes. In other countries, we have other codes. But these codes need to be implemented and used across all health facilities in a country. So ICD-10 and the procedure codes. But in addition to that, you need to have medical coders, because not anybody can just do the coding. And if you don't have good coding, well, if you don't get good data, then you won't get, if you won't get good data into the system, you won't get good data out of the system. So we also met with the African Center for Data Science in Kigali, and discussed with them, the opportunity to introduce a health information course to offer medical coding training to students, and that can be set up in collaboration with international universities. And this university or this data center would then train the future medical coders for hospitals in Rwanda, as well as for Africa, because there is currently no single African university that actually offers medical coding training, okay? We are advocating to introduce ICD codes across the world, but we don't really think about what does this mean about the coders, what kind of training we need. And actually, I do think this is quite an opportunity, because, after COVID, we saw in South Africa, for example, that there were lots of nurses who had, from the hard work, post-traumatic stress, and could not go back to treat patients at the bedside anymore. And so South Africa is actually considering how can these nurses be used in administrative work. And these nurses would actually be the perfect coders of the future. So, we could think about a program like that to bring staff who is not able to work anymore at the bedside of the patient into this kind of administrative work. And still use their medical knowledge. Now, on the second component that we used for the with the GFF fund was about analytical capacity building. And what we did here is we tried to clean claims data from 2019 and 2020 to see, what has actually been the historical use of data, as well as what kind of data quality do we get. Now, I'm sure I'm not telling you anything new here, but the data was mainly transferred in the past in an Excel file from providers to the RSSB, and that Excel file was full of mistakes because there was no pull-down menu in the Excel file, and so people could enter whatever they wanted into any code, into any column. It started with the dates being done in American format or European formats, misspelling, incomplete data. So the data that were received in that Excel form was, sorry, but it was not good. So one thing, but they didn't have a claims form at the time. So what we then helped them was, let's develop at least an Excel file with a pull-down menu, and they really liked that, so that the format of the date, for example, cannot be altered. You have to use that one, and so on. We also developed guidelines on how to do data cleaning, and we organized a training course in a narrated PowerPoint, actually, on how to enter the data in this Excel file, and this can be used by the health facility data entry clerks. So that was done in 2020. We also produced guidelines on how to do data quality checks and cleaning. And we prepared a note on preparing the data sets for analysis, right? Because there was actually no guidance to the analytical team on, once you get the data, how do you clean them for analysis? And there are some certain things that need to be done here before you actually can analyze an Excel file with the data, and they need to be done consistently. So we prepared these notes for them on how, and provided training on how to do data cleaning from an Excel file and prepare a data set for analysis. We then conducted some analysis also based on the claims data, actually from the RAMA data set, which was in best shape. RAMA is the formal sector insurance. And but the data did not provide us with a lot of information. For example, there was no procedure, there was no, it was more or less an invoice. Okay, it was telling us how much did they pay for lab tests, for example, but we had no clue what kind of lab tests were provided. But we could do some analysis on descriptive analysis and provide some recommendations also on how to improve the data and the analysis situation in the future. And we made several presentations on that based on the RAMA data set. And also this was super helpful also to inform the capitation payment reform as well as the claims format. We also started to develop an annual work program and set up a workshop on data analytics. However, then a new CEO came in. So we had several trainings on that. We actually also invited people from other units, including Owen from and other India-based staff, to talk about how they do analysis in the India Health Insurance Fund. And so we had several trainings and workshops on this. But then a new CEO came in and he decided to change the analytics team, which is a good decision. And this whole training is now on hold and will continue in the future once the new team has been assembled. Moritz and Johnson also prepared a public expenditure review health chapter under this fund, under this technical assistance, and this was actually it's just being published now. And one of the key findings, I'm just going to show one slide of this, was actually big surprise to everyone, that health insurance, the RSSB, only finances 13% of total health expenditures in Rwanda. Okay, so actually, if we talk about health insurance, we are talking about a very small share. It's not so big. Half of the total expenditures are financed by the government, which is good. and development partners is 27%. What is very good is that out-of-pocket spending is only 10%. That's actually excellent if we compare it against this high service use rate, which suggests that the insurance is having some impact on protecting people against out-of-pocket payment. And that's also what we saw in the household survey analysis from 2017. So, and then the third component under this technical systems that was financed under the GFF was really very targeted technical assistance to the RSSB staff working on IT investment needs for health insurance. And this involved several policy notes, including here a note on the health insurance minimum data set that should be collected. So actually, I have to say this was quite something. The RSSB had, when we started this work, the RSSB had already hired an international company that was financed by the government to set up the whole IT system for insurance, because this insurer is managing not just the CBHI, but also pension, savings, and the formal sector insurance, right? So that's actually the right way to go. But something happened along the way, and that contract got cancelled, and they ended up with no IT system, okay? So that was not ideal. And the new CEO then hired local software engineers to develop the IT system for the RSSB. That's a good thing, but these engineers came from agriculture, they came from all kinds of sector. None of them had health insurance experience. So they really needed hand-holding on what kind of software is actually now needed and what kind of IT systems. So this required quite a lot of dialogue from our side also, and support to them. And at the end, we could actually convince them that they should apply to another World Bank project that is ongoing, the digitalization project, which includes a 10 million allocation to the health sector. And we supported them in the development of an application to that project, so that under that project, a firm can be hired to set up the IT investments that are more or less, off the shelf across the world for health insurance funds, as well as pension insurance. So this is now ongoing, and I hope they will have a better experience in the future with that program. So on the next steps, that was more or less the work that has been done now in the past 2.5 years, and this technical assistance goes on until June 2024. We have just received an extension actually, and the team will continue this work on health insurance operational management. There are several options here that I am just talking about, but need to be agreed upon also and finalized with the government. One is finalizing and implementing the CBHI benefit package based on the actuarial analysis. Then technical assistance to the capitation payment reform, and to continue to provide just-in-time technical assistance to the RSSB on health insurance operations. Then, of course, analytical capacity building should continue. That is not just to the RSSB, but also on the provider side. I think now with the capitation payment, since this can set quite a number of adverse incentives, as we know, it will be important to do analysis on the provider side to make sure, the capitation does not have an adverse effect on providers, which could be, that they just cash the money, they just take the money and refer patients to the hospitals who are still getting paid fee for service, which is not ideal. But also, I think it's definitely a need to do more in-depth analysis on the quality of care, on service use on the provider side, and that is currently being set up. And I hope this will continue in the future. And then there may also be a need to continue technical assistance on the implementation of this health insurance management information system to the team as this work continues to be financed, hopefully, under the digitalization project. That's the other big project that the World Bank is managing in Rwanda. So that's it in a nutshell. Back to you, Ellen. I'm happy to respond to any questions that may come up.
Thank you very much, Pia. That's quite impressive, very comprehensive program in Rwanda. I have a few questions, but I'm aware that some people might need to leave earlier, but at least I know Owen has to. So I want to make sure that whoever wants to come in and has a time constraint can do so. So please raise your hand or come in if you'd like to comment, or use the chat to flag that you want to ask a question. Okay, if not, I'll start. But oh, and I'll see a hand go up. Pia, we can't see you. I think you're trying to share screen, but it's just only your name. I don't know whether it's.
Yeah, no, I am actually not sharing a screen anymore.
Okay.
I'm sorry, I have a hemorrhage in my eye, so I try not to show my video. I look a little bit weird, so probably I'm just going to show myself from my left side, from my right side. Okay. I did not get in a fight, so.
No worries. Owen, you wanna kick it off with a question or comment?
Sure. Thanks, Ellen, and thanks very much, Pia. This is super interesting, and there's clearly a whole lot of work has been done. And as you said, I got a little glimpse of it a year or two back when we had that exchange, and it was clear that there was a lot of really excellent work happening. So I had a couple of questions. One is kind of a bigger picture issue. You know, the sort of reforms, particularly the provider payment reforms, but more broadly, sort of the insurance design that you describe is pretty common in a lot of middle-income countries. But what sort of sets Rwanda apart, it seems, is that they're doing this at a much earlier stage than many other countries have done it. And I wonder if you could comment on, you know, the sort of the weather to do these reforms. We debate all the time. We don't talk very much about when to do these reforms. And because Rwanda is kind of unique in doing these at a very early stage, I'd be interested in how you sort of see whether some of this is premature, whether the implementation challenges you describe are sort of insurmountable or surmountable, or just what you think about the timing. The second question I had was more specifically on the benefit package and the work that you said is still being done on prioritization. I think one of the slides said, okay, the criteria is to look at financial cost, morbidity, and mortality, and then a prioritization will be done. But we know that one of the sort of central challenges of benefit package design is that if you emphasize financial cost or financial protection, it kind of takes you in one direction. If you emphasize mortality and morbidity, it sort of takes you in a somewhat different direction, and it's hard to reconcile those. So sort of concretely, can you say something about how they're sort of doing the prioritization when you have those sort of opposing forces that are pulling the design in different directions in terms of the content? And I guess my third very brief comment, not a question or a comment. I mean, the IT, I was struck by what you said about the IT, and they had a contract that was canceled and they ended up with nothing. It just seems like everybody has this problem from Obamacare to the NHS in the UK. I mean, to so many different countries, the IT always seems to be a mess, and I don't know what we can do, if anything, to try to help countries along on that front. But thanks again. It was a great presentation. Over.
Perhaps, if you don't mind, Ellen, I would like to respond right away to Owen.
Yeah, sure.
So, as you probably know, the CBHI in Rwanda is not a new scheme. This has been going on for a couple of years now. Actually, the pilot phase was from 1998 until 2000, and based on that, the government then decided to scale this up. So Rwanda has an experience of, you know, more than 20 years with CBHI, and it was not an on and off. It has consistently continued this work. But what I do find now is that they need to be careful about not overloading the system with reforms, right? There are lots of things that they want to do, but that you also need capacity to do those things. And there is just simply not that much capacity available. So I do think we need to be really careful about making sure, do we have capacity to really implement this? And that, you know, that it highlights the importance of sequencing the reforms. And like capitation payment, we talk a lot about capitation payment, but actually during the pilot phase, the CBHI started with capitation payment, and then after about 5 or 6 years, they moved over back to, they changed from capitation to fee for service. Why? Because enrollment in those schemes was still low. At the time, enrollment was probably around, you know, 15%, which means you have adverse selection into a pool, and then it is mainly the sick who are seeking care, which means the health center managers, they will actually compare how much money do we get on the capitation and how much money do we spend on these patients. And they were not happy and reintroduced fee for service, right? And so you need to be careful at what time can what be implemented. If capitation is being implemented at the beginning and you don't have a high enrollment rate, it will likely fail because health facilities will not be happy about the amount if you have fee for service. So, but in Rwanda, this is at a different stage. We are now, you know, at an enrollment rate of 75%, and certain things have been addressed that needed to be addressed, but there are still lots of things that need to be addressed, right? So I do think, you know, that priority should be given, certainly, and that needs to be done in collaboration with the health facilities on data collection, data transfers. That requires some IT systems and in the health facilities as well as in the insurance company, and then setting up the payment based on that. But the sequencing of reforms is really important, and also you know, making sure you have the capacity in the country to do that. On the benefits package, I would like to do actually a more detailed presentation on that, but I did not. The way I only showed actually 2 bullet points from that decree, but there are many more. So they have actually agreed on a couple of criteria. So population health, effectiveness, efficacy, and so on, right? And what they are now doing is they take these criteria and they rank all the conditions or diagnoses and the treatments that go with it in a prioritized list. And then you end up with this prioritized list of services. And at the bottom, you have probably some things, like I mentioned, rhinoplastic or some other things that are, you don't need necessarily to see a doctor, or me with my hemorrhage here in my eye. I don't need to see a doctor because we know, I learned on Google, it's going to go away within 2 weeks, right? I just have to stick it out. And so these kind of things will be on the bottom of the list. It's not going to be covered by insurance. And so what the actuary then will do once he or she receives that prioritized list is compare it against the budget and see, okay, what can we pay for, and do we have the money to pay for all 600 items on this list, or does it stop at line item 400 and whatever is below? Well, we need to see, you know, probably all the big important things are above the line and will be covered, but there are some things that will not be covered because, well, first, it's probably going to heal by itself. And 2, you don't necessarily need to see a doctor, or it's just less important, right? So this is the decision we need to make. But, you know, making sure that the treatment is not having a catastrophic impact could be a criteria to define on whether it should be included or not. Right, so this is a criteria that can be used when you actually establish the prioritized list. Yeah.
Thanks for that, Pia. have a few questions as well, which, if you don't mind, I'll ask, and then people want to come in or raise hands, please feel free to do so. So a few technical questions, perhaps on the reform agenda in Rwanda. It sort of struck me that enrollment is indeed quite high, and you didn't really mention that in the TA package, probably because it was quite high, but I think quite a lot of us, and perhaps colleagues on the call as well, sort of are struggling with that issue. How do you get enrollment up in countries with high informality? So I wonder whether you could reflect a bit on how that enrollment got to that high proportion, and what sort of the vision is for increasing it further to 100%, and sort of whether that's something you imagine being part of the support as well, especially because only, what was it, 13%, I think, of the current government expenditures are going to the CBHI. So I was wondering, that doesn't seem to signal that it's heavily subsidized. Then how come you get such high enrollment? What is there for other countries to learn from? In relation also to the high, I think 30% of the spending of the budget comes from other development partners, external resources, and I see Rogers also flagging this issue of low government funding vis-a-vis the external funding. I was wondering, given that relatively high donor dependence, what was the role of other development partners within this package? Is it just very well understood that the bank has a competitive advantage in this team and provides the TA, and other donors focus elsewhere, or was there some sort of consensus and strategic alignment? I know from very recent workshop we had in Kigali that, for example, US State is very much investing in information systems. So I was wondering whether you could reflect a bit on that dynamic. And then a third the donor-funded project into a government system, and often we tend to see the insurance agencies and programs as a way of mainstreaming RBF, sort of trying to have these functions go into the CBHI function or the insurance function. But I think that, if I understand it well, in Rwanda that hasn't happened like that, right? The two coexist quite separately, I think, at least. So I wonder whether you could comment on that link between RBF and CBHI. And then a final question, perhaps a bit more about the political economy, but it might also reflect my ignorance on some of the bank instruments. But I thought it was interesting that a lot of this is linked to a development policy loan. I'm much more familiar with this sort of TA in relation to a P4R or an IPF. And I wonder, sort of, is this just because this was the opportunity there was in Rwanda, because there wasn't a bigger health P4R or IPF, that you took this opportunity with the team to link it to this? Or is there sort of more, was like, what are the competitive advantages really vis-a-vis more sort of regular investment project financing, or even a P4R vis-a-vis a DPL in supporting this kind of program? You started off with the DRM trigger, which is quite interesting, but on the other hand, I'm thinking, yeah, government knows this, right? The government knows they need to fund on the basis of who is enrolled and need to have a transfer. So is a DPL in this case then just sort of an additional small nudge, or to do something the government is fairly aware of and has on the agenda, or did it really sort of trigger an agenda that was a little bit paralyzed before? So I'll stop here, just so you can pick and choose which one you think are the most interesting to reflect on and share with other people on the call.
Yeah, okay, let me just respond to those. Rwanda has now, the CBHI has an enrollment of about 85% of the target population in the meantime, right? So it's quite high. The reason why, it is compulsory to get insurance in Rwanda. So you have to have health insurance. And they actually check this. So if you want to have a government driver's license or something, or you need something from the government, they actually check this, whether you have insurance or not. And if you're not insured, you won't get the service until you purchase insurance. So the reason why enrollment is so high is probably because it's going on for such a long time, more than 20 years, the system is there. And it has been compulsory, enrollment has been compulsory, like social health insurance. In OECD countries, it has been compulsory since a couple of years now. On the other development partners, yes, there are other development partners, and we have benefited from them quite a bit. The USAID project, but also WHO have provided technical assistance to the program. The Gates Foundation is financing the London School to do the whole prioritized list with the treatment, standardized treatment, together with the Public Health School. So there is actually quite a good collaboration across these development partners, and also very coordinated to benefit from each other's capacity. So that has been really good. On mainstreaming RBF, so I would, any time when you develop capitation payment, it's good to start with crude capitation, which means basic capitation, not to overload it. Just start with simple, because it's already quite a shock to the system to move from fee-for-service to capitation. So don't start adjusting it by risks or something. Besides, the risk doesn't really vary across those rural areas in many African countries. So go simple, and start with simple, and then in the future, eventually RBF can be added to the system. Now, indeed, Rwanda does have an RBF contract, but this is part of the fiscal transfer from the central government to the regions. It's a decentralized system. And this is more or less an agreement between the Ministry of Local Administration and the mayors. And they get a certain amount of RBF, results-based financing, if they meet certain criteria, right? This is not just health criteria, but health is part of it, but other criteria. We recommend that in the future, actually, that transfer should be rerouted through the insurance scheme, at least the health part of it. But that should be in the future once the current payment has been really set up and is working well, the crude capitation. And if they decide to do adjustments, then this can be done through that RBF, right? Let's use the RBF through the RSSB, who will hopefully by then also have better data, because currently this is not very good data being used for this, and the RSSB will hopefully have better data in the future to have a more solid background to actually develop a good RBF through the health facilities and regions. Now, on your last question, linking technical assistance to DPF, actually, when you work on the DPF, and I think those of you who have attended the DPF discussions in the past, we have mentioned this several times, I guess, you don't really get a lot of BB from the CMU to support the implementation of a DPF, and which means you don't really have a lot of charge time. So if you don't have at the same time a code, a technical assistance code from the CMU or a project to charge against, it will be very difficult to actually deliver comprehensive technical assistance to that reform program. And very often this means then, okay, if we don't have time, then we just have to scale it down. And I think the beauty about working in Rwanda here with the support of the GFF money was really, we had a program that gave us money over 3 years, where we knew we're gonna be able to use this budget. It was 500,000 in the first 3 years to support and finance technical assistance to actually do all this work, right? If without this would not have been possible, because the money we received under the BB from the DPO, from the human capital DPF, was not a lot. That hardly paid for a mission or two and some time. So actually having the GFF technical assistance was really crucial to develop this. And I have worked on a couple of other DPFs in many years ago. I remember that was before the GFF existed. It was the same thing in Serbia or in other countries in the European region, where we had development policy lending at the time, where really thanks to a large technical assistance program, we could actually finance, and implement an interesting DPF program or policy program under DPF. Now, actually, this technical assistance can also be used not just under DPF, but of course, can also be used to support the implementation of a P4R or an IPF if you need that. And I'm pretty sure many of you are already doing this. I hope I responded to your questions, Ellen.
Thanks a lot, Pia. Yes, you did, and it's great to hear how that support was so well used behind such a comprehensive agenda. Perhaps I don't see any more hands up, but please come in if you want to ask.
Oh, I think I've got
the final question then, and then we can sort round.
Sorry, Ellen. I think I forgot to respond to one question about the high enrollment rate and only having 30% of total health expenditure being financed by the government, right? By the RSSB. Yes, absolutely. The reason why is, expenditures is price times quantity. So it's not the quantity, it's the price, okay? So currently, the RSSB is paying a very low share of the price of the expenditure. And that's the reason why we have such a low share that actually is being financed of total health expenditures. So, and that's the reason why I'm saying in the future, you really need to have, if you think back about this slide that I showed with all the different sources, you need to have a discussion with these different sources and to say, okay, how much of these total expenditures who is going to pay how much of these total expenditures, right? If the RSSB is going to pay some of the pharmaceutical expenditures to treat disease number 1, how much are the other development partners paying? How much is the government paying? And should we really break this all up, or should we only have one source who pays for all of it to prevent double payment? So this is the discussion that needs to be held on a national level, and I think the PR did a good job in inspiring this.
Thanks, Pia. Thanks for the clarification. Just doing a final check. I see no more hands up, so I think you've been very, very clear in explaining. I think we can sort of aim to wrap up within the hour then. I at least personally thought this was extremely helpful because it ties together a lot of the questions that I think many of us are struggling with. I think, Pia, we can share potentially on demand if people are interested in accessing the presentation or additional some of the things you mentioned, like the claims forms and the TORs even. I imagine some of the country teams might be interested in accessing those, but they should feel free to reach out, and then we can see what and how we can share in what form. But with that, I think we can close today's webinar. Thanks again for sharing these experiences. Really useful, and I hope we can continue to discuss their impact and the results that are to follow.
Thank you very much for attending, and feel free to reach out to me if anything was not clear, or if you would like to have any of the PowerPoints that we produced or additional information, and I'd be happy to share it.
Yeah. And we did record, so I see some people asking in the chat, send me an email, and then we can see how we make that available. Happy to share. Thank you all. Have a great rest of the day, and very happy holidays soon. Bye all. And thank you, Pia.
Bye-bye.
Bye-bye. Thank you, Pia. Bye, everyone.
Thank you.
Bye.
Thank you so much, Pia. Bye-bye.
Bye-bye. Thank you.